Yeah, so some people trace it back to the 1600s when this gentleman Henshaw put people in this metal tube and then increase the pressure in there by either increase it or decrease it, try to cure ailments they didn't know much about, lung and liver problems. Eventually, the first diver's helmet came out in about 1838. Although they was tethered to the surface, they did get air and they were able to go below the surface of the water. Caisson's disease you may have heard about. One of the more famous places is, of course, the Eads Bridge, which was documented in 1871. Caisson's disease is now called decompression sickness, and they'd put these people down into these tubes to work down here to get, you always wondered how these things stayed up, but they'd drill down and they would work under pressure, and then after working, they'd come back to the surface and they'd have all these symptoms, elbow pain and everything else. And this is the Brooklyn Bridge from 1873, and this is how they diagnose decompression sickness, because they'd feel great down when they're working, but come back up and they'd have all these ailments. Eventually, a guy named Paul Burt figured out about the bends and decompression sickness and that it's all due to nitrogen bubbles. It's just all the symptoms you see there, joint pain, numbness, and paralysis. And at time, they learned a little bit more in the old age of hyperbarics. Really didn't start until really the 1950s when we learned everything. I don't know if anybody knows about this. This is called the Hyperbaric Hotel. It was in Cleveland, Ohio before they got rid of it. A guy named Timken was cured by Dr. Cunningham, so he got real happy, and he built him this hyperbaric hotel, which eventually was hooked to, I think, a psychotherapy center. But remember, in 1928, they did know about oxygen, but they didn't know about pressure. So people would smoke in here, and they go there to feel younger. But they didn't blow the place up. Eventually, they tore it down, unfortunately. The modern age really started in the 1950s, when they really learned about high pressure along with oxygen made all the difference in the world. The guy on the left is Jefferson Davis. He's just one of the pioneers, and then the gentleman on the right is Churchill Davidson. But a gentleman named Borima in 1956 is when we really started to know things. Figured out you could operate under pressure in a operating room and keep the patient alive. He then operated on a baby pig and took all the blood cells out of him. So he learned, yeah, you can stay alive with no blood in your system. They didn't really understand it that much, but at 3 atmospheres of pressure, he was able to keep that pig alive after soaking him in O2, supposedly. He wrote a book about it called Life Without Blood. So the definition of hyperbarics is treatment in which a patient breathes 100% oxygen while inside a treatment chamber. And this has been a point of conjecture because there's a lot of people who have these portable units you may have heard of. I think there's somebody in St. Louis who has some of these portable units. And so they decided to say you had to have more than 1.4 atmospheres of pressure. Right now we are at about 1 atmosphere of pressure. So ATA means absolute atmospheres. And that's basically 760 millimeters of mercury. This is a Class A chamber. This is called a multi-place chamber. You can put 8 or 10 people in them. There's none that I know of in the Midwest. If you want one, you almost have to go to Texas. But these people lay in there either in a stretcher, and most of them will put on these hoods that have an intake and an outtake, and if the intake gets clogged, this will shrink wrap around their face. It doesn't happen very often, but it can shrink wrap. This is good because this is an air atmosphere, so you can put IV tubing in there, and you can put all the things that cause static electricity in there, and this is called an inside tender. These people sit there and breathe air like they're going diving all the time. So if they sit in there for 2 hours, they're like going diving. And so they have to even be decompressed because they'll get decompression sickness. So some of them have doors and chambers on the outside, so they'll change. They'll equal the pressure on the outside part. They'll climb through, somebody else will climb in so they don't have to undergo treatment. This is what we have in our chamber, probably the places you all been, that's what you got. This is a Class B. It's a monoplace chamber. This part opens, you go in there, there's dials on here and an intercom. This is the most common one where usually only one person can go in there. Once in a while you can put a child in there with the mother. But you got to be real careful. The mother took a doll in one of them in a different country, and it blew up because it had a battery in the doll. And that's not good. This is the veterinarians use them a lot. That's not my dog, but they use them for different ailments, and that's a Class C chamber. This is a portable hyperbaric chamber. We actually used this when I was a resident on vascular surgery. Gary Peterson, if you know Gary over at Mercy South, used to use these when I was training. The problem is they don't work very well because they put oxygen in there, but it's not absorbed through the skin, so the only place it can go is the wound. Unfortunately, it's not really enough oxygen in order to make a difference, so most of them have been somewhat banned. Here, doctor, there's a chair just for you.
I got one right there.
Oh. So those are the different types of chambers. This is one that they're trying to outlaw. This is a portable unit, which I think some people in the States used because it's cheap. It's got an oxygen attachment, and then it's basically folds up, and you can take it wherever you want to go. There was a story of somebody in Beverly Hills who was using it for their kid who had cerebral palsy or something. And one of the neighbors in Beverly Hills were getting worried because the oxygen trucks were pulling into their driveway all the time. And they had blogs, and all their friends and kids with these illnesses were going in there, and they were using it, so that they got rid of it because it's very dangerous. One child died because the oxygen disconnected from there and he asphyxiated. But they don't, if you put pressure on that, which you can't put more than 1.4 anyway, it's not going to do a lot of good. If you put too much, this will rip and come apart. A guy named Haldane figured out this Haldane's principle and ratio, but basically what it says is if you add more pressure, so this say is the alveoli and this is the fluid in the lung. He did it a little differently back then. You then will force, you'll get, say you increase it from 1 to 2, you'll force more oxygen molecules into the fluid. And so that's the secret behind hyperbarics. It's not saturating the hemoglobin, it's actually putting more oxygen in the fluids, in the blood. As I said, you can take all the blood away from out of your body and you could still keep you alive with this, and I'll show you why. And so eventually you get more air in there, you get 100% oxygen, you put it to pressure, and you have more oxygen in the fluid. So what happens when you do that? This table up here shows how many milliliters of oxygen per 100 milliliters of blood. Normally in 1 ATA, which is where we're sitting today having this talk, it's your PO2s say about 100 to 150. I guess this is a European unit because it should be not a comma. 19.7 per 100 milliliters. Add a little pressure and it goes to 19.8. If you put it up to about 3 ATAs, the amount of oxygen you add because of the saturation curve, you can see it's over 80 to 90% with a PO2 of 60. Now make it 100 and look how much more oxygen you're putting in there. You get about a 2% increase. Look what happens to the quantity in the plasma of the blood. You go from 0.2 to 0.4 up to 6. It's a 2,000% increase. And that's because if you look at the equation, the pressure, the amount of PO2 in the alveoli is the total pressure. This is in millimeters of mercury. So that's 760 here, 1,600 here. You go up to 2 or 2.4, you multiply it by 100% O2. You can see how just increasing at 1 increases the oxygen so much more. I didn't have this thing on there until recently, and this was all supposed to give what this is. These are constants, really, so you don't worry about them too much. But you can see how much oxygen we can get in the system in somebody in a hyperbaric chamber. 2,000. We can get their oxygen up to 2,200. Try doing that anywhere else. You can put a face mask on somebody and get their oxygen up somebody. You're only going to get it up about 2%. At the tissue level, we need a PO. Oh, it depends where you go. There's some places that will treat you cheaper, but you know, mercy. I think they charge around $2,200 a step.
Mercy. So basically 30K. 20K.
If somebody wanted to come, and pay out of pocket, I'm sure they give them like a 30% discount. But there's also a foundation that's paid for several of our patients who don't have any money, so they will try to work with them as much as they can. But as he heard from Mark, this is all about money. That's all it is. And you'll see when I get to the end. If you want me to skip all the osteo, I'll be happy to, because we could talk all night. Does it really work? Does it not work? How long does it last? How long does it really last before you have to do it again? There are no 100% answers. But it's a variable in treatment that you don't want to give up usually. I had a guy call the office once. He said, tell me who will take out my teeth. Find me a dentist who will take my teeth out without HBO. We said, oh, I don't know. He was calling all over the city to find somebody to do it. I guess he did. What's his...
It is becoming more, when you call me up on my cell and I'm in Greece or somewhere and you're like, I need an audit. I'm being audited or whatever. I mean, it's becoming a pain in the ass.
Well, you called me in Aruba.
I know.
It's a cat, man. That's the way it is.
And she did well, by the way, right? Yeah. But that's good. I'm always available. You know, it's funny. But so there's all sorts of definitions. Like I said, some people I guess you all use 8 weeks. Some people use 6 months. Mark's use 6 months, 2 months. But basically, it's all over the board. I don't know if has the society decided now on a simple diagnosis. I don't know. But it was interesting seeing all these people do that. What's the incidence? Nobody knows. 5 to 15%. Depends how much. If you get less than 6,000, they say 0%. 6 to 7, 1.8. You go over 7 and get fried, 9%. You know, but basically, what's happening? You get hypoxia in the area, hypovascularity, hypocellularity. Now there's a new way of looking at it, fibrosis. The mandible, of course, is more prone to it than the maxilla. There is some mention that they're going to stop paying for maxillary teeth. And that came from the meeting I went to a couple years ago, because the maxilla has such better vascularity that it may not make a difference. I don't know the answer. But you know the symptoms, the exam, but it depends on the type of radiation. The risk factors, of course, are people who smoke, poor nutrition, a lot of radiation, exposure to the mandible, infection. I think Dr. Morris had one that was infected at the time. We were able to treat him all the way through before it became so bad he could get his teeth out. All these different stagings. Is there one staging everybody uses? Use Mark's. Mark's stage, interesting, is based on HBO, though.
Yeah, that's a lot of other time.
Yeah, but so basically he says it's stage 1 unless it doesn't work, and then you go to stage 2 and you end up doing a sequestectomy. So you're basing it on HBO, but what if they don't have HBO? So some people,
We just don't respond.
so there's other ones like, does it just get the alveolar bone? Does it stay above the alveolar canal? Does it get to the lower border? I don't know. But it's interesting, Mark, I don't know how much people are still using Marx's, because he bases it on HBO, you know. Now they don't have a fracture or I guess a fistula, and this is just Epstein and whatnot. And then there's this beautiful picture of Lyons who said, oh, it's whether it's 2.5 or less of centimeters. Does it involve certain parts of the bone? Do they have a fracture or whatnot? So there's different ones. This is the thing I want to say. Does it work forever? We all know that, I guess, that radiation comes and then it gets better for a while. And this is that golden period, I guess, when the effects of radiation aren't that great. But then it takes off slowly over time. And this is 7 years, they think. So if you do HBO, what they think is it drops it down. So that line of hypovascularity and whatnot drops down. Eventually, it's going to cross the threshold, you would think, and there'll be a high risk for getting a problem. And that's why they don't think it lasts forever. Now, granted, this one goes across at 6 years, but I think this is why they think it's not good forever. Yeah. The question is, if you got somebody who's 5 or 6 years out, is it better? Is the risk outweigh the benefits of it? You know, there's really some risk with the heart and the lungs and pneumothorax and boredom and cost and everything else. So let me show you this is Marx's study from 1983 when he treated people with this, and his criteria here of healing, but he had he got a lot of tertiary referrals when he was at Wilford Hall. So these are all very sick patients with refractory ORN. They may have had surgery. He used Marx's stage, which is again here. And he treated them with, in stage 1, he'd do 30 treatments. And that's still the treatment today that we use for people with ORN. Now 20 treatments is what you use for extractions. And if they didn't get better, sorry?
20 is still prophylactic, but Medicare won't pay for prophylactic.
Well, if you're going to treat them as if they're ORN, you got to do 30 supposedly. So we can't say do 20 and say we're treating ORN. I guess Medicare could come in and say, hey, you only gave them 20. You should see what the OIG is now. They want us to self-report patients that we didn't get all this data on. And they're going back to even 2010. So we do 30 treatments. He did 30 treatments. If they didn't get better, they now became stage 2, regardless of how much of the mandible is involved. And then they go and they get surgery. So how many of them got better? They get alveolar sequestrectomy. And if they healed, great. If they dehisced and exposed bone, then they're in 3s. And then they get a mandibular resection and a total of 60 treatments. And these refractory ones, boy, they would get treatments and then they'd wait and then they'd bone graft them and do 10 more.
This, right? Because that last slide that had the 30 treatments, you got 4 years of oxygen peak, right? So the 60, does that mean anything?
Sure. Because these are people who haven't healed yet. These are people who don't have ORN right now. These are people who don't have open wounds right now. This is people who need treatment, not the people who still are being treated for ORN. So it's a different subset. So that was Marx's 1983 study, and here he went through there. And the interesting thing is 41 of his patients were stage 3 because of his referral base. Okay. And so he had 9 patients with stage 1. So he had 10%, 20% who healed on their own. And then some of them needed to have extra treatments and more surgery. Okay. So he did another study, and this is a study about prophylaxis. He randomized, and this is the important thing, he randomized all these patients to either penicillin or HBO. Okay, they got IV penicillin and nothing else, they actually had sham hyperbarics, I think. And the number of treatments was 2010 at 2.4 for 90 minutes, which is what we still do now, and these 3 people did this. And he said 29% of the people who just got penicillin developed ORN, and only 5.4 who got HBO. And that's still the numbers I quote my patients today. This is the definitive study why we believe Marx. It's randomized, it's unbiased, supposedly, all done at like 2 or 3 centers by the same people using the same technique and being very gentle in doing that, at 29.4%. So then the question comes up, if they've had a malignancy, and I didn't go into all this, I just put these up there to remind myself to tell you, they've sort of proven that it doesn't accelerate the malignancy giving them oxygen. You think that if you gave them more oxygen, they'd have a higher chance of cancer. Some people now believe that with the free radicals and everything, it competes against it and there's no increased risk of infection. And so they concluded there's no evidence of malignancy should be considered a contraindication. So then Marx did another study, and this one isn't as well versed in my reading, but he did 160 patients for soft tissue flaps. So if you make an incision in radiated tissue, they really should get some hyperbarics beforehand because that's hypovascular. And this is when he was at Miami. He's still at Miami, isn't he?
Yeah.
Yeah. Quite a place, I hear.
It's an interesting place.
Yeah. So these are people who needed major soft tissue surgery or flap reconstruction with more than 6,400 rads. One group got surgery and the second group got to 2010, and he found that the wound infections in those who didn't get any HBO in group 1, and you can see major problems, 16% versus 2.5. The wound dehiscence, as you can see, was much more, and delayed wound healing in 55. I mean, this is what he showed. And it's a randomized trial from Miami where does he look the same?
No. He's 30 years ago. A little bit. Well, his hair does.
It's the picture I found of him.
It's the hair color.
So what Marx did is he showed us that hyperbarics is not a standalone treatment for ORN. It's a multidisciplinary approach. We're not trying to take, otherwise we'd be taking patients out of your hands, and we don't want to do that. We think they should all have surgery. Some heal, but And so he established that it's not a standalone procedure. You have to do them beforehand to get that extra oxygen by 18 to 20 treatments. He did show that it works for extractions. I don't know why they decided not to pay for it. Because what? Because it's only 30% of patients will get an infection and 60% won't? But those 60% that don't, the 30% that do cost much more money. I didn't put the slides in there, but there's data to show that they cost a lot more money to fix the ORN than it does to prevent it. But we all know what the government does.
No question.
Yeah. And he,
I told this guy the other day, he told me the bad things about this HBO. He goes, I don't think I want to go through it. I said, you get this osteoradio necrosis with your cancer back. It's devastating.
yeah, it is.
And I had a guy, they opened the center up across the street. You know that.
Which one?
Mark Ledley.
Yeah, Mobap, yeah. Yeah, I've known Mark since he was an intern.
Yeah, so I started dealing with Mark, and then Mark started doing these, sending me cases that he's like, well, they need 60. I said, 60? I said, where are you coming up? 60 dives. Before you up? It's,
Did he tell you why?
it got to a point, it's like, no.
I know Mark, but he does work for a for-profit system called Healogics now. So I don't know if that's it, but I'm suspecting that they're going to have a lot of trouble.
It's under the RVU thing.
Yeah.
It's an RVU thing.
Well, I work on RVUs too,
Well, we
but
all-
but I'll treat you like I treat myself, and I ain't putting myself in there unless I think it's going to change.
I know, yeah, but we probably have smoke jabs. I'll be out of there before that happens. Michael,
Yeah,
we'll be very close.
yeah. But these luckily at Mercy,
I'm not doing CPR on him either.
yeah. I'll be honest with you.
I'm DNR, so.
I'll be honest with you. Mercy has made zero requirements on me. They don't tell me how to practice. They don't tell me I got to put people in there. These for-profit places expect a certain number of patients in the wound centers to make it into the hyperbarics, and I don't know if they're going to end up having problems monetarily.
I had this gal that ORN, nightmare case, blamed me for paralysis. The lady continues to, every time she walks in, she smells like the
Cigarette?
Las Vegas casino.
Yeah.
We have to air the room down because of the smoke smell. And I'm like, this is never going to work. He goes, let me give her 20 more dives. I'm like, no, it's going to end up with pathologic fracture.
Well, she'll get oxygen toxicity is what she'll get.
Just a nightmare case. We'll just give her 20 more dives.
Yeah, and she'll actually get an oxygen toxicity. You remember Avajian started the wound center at Mercy, and he used to give everybody 100 drives. He used to give everybody 100 dives or more.
Avazian?
Yeah, that's what I heard. But if you do too many, they get oxygen toxicity. Their cataracts get worse. They end up needing cataracts.
Never did that. Raj was always 20, 30. I never could figure out the difference between whether you guys do 20 versus 30 or.
I'll show you at the end the protocol I use. This is what I was taught when I took the course in 2014. But there's I guess logic to it. I mean, it depends on your readings and things. If you're on the side that ORN doesn't need hyperbarics, you'll go with this guy Anane's thing. But let me show you. But he demonstrated also that it wasn't an infection process because he did biopsies and cultures and things. And he also did biopsies showing that blood vessels grow in angiogenesis.
Remember my start,
Yeah, he left in
how long ago was it?
December 2013 because I started in March of 2014, and the trauma people covered it for a few months before I came. But I don't want to go over these, but basically there's just more studies that showed Marks was right. I think it's 94% of the people did well. So, and Hampson, these guys are, and Feldmeyer, he's one of the deans of HBO. More of these, Cochrane showed good results with hyperbarics. Then there was arguments in the 1990s. I think this is 1997. Yes, you should do it for dental extractions. No, you shouldn't do it for dental extractions. I mean, they were arguing back then about it. No, it doesn't help. Yes, it does. Well, there's a 30. So you're going to have these arguments even today, and you just have to do what you feel is right for your patients. We feel that If the risk doesn't outweigh the benefit, it's beneficial. If it's somebody who's got bad emphysema is going to rupture a bleb and get a tension pneumo, well, no. If they have heart disease and they have an ejection fraction under 30%, well, the risk might outweigh the benefit. So what they found was Marx is still to this date the only randomized trial. I find that amazing that nobody did a randomized unbiased trial, and the 29 versus 5%. And then the guy who said you looked against it, he said, yeah, these aren't very good studies, but they're only grade C, I guess is what they called it then. But he still argued against it. Same thing, this study that he quotes based on weak evidence, but still said HBO was effective after extractions. And then came this guy in 2004 named Anane. And he did this study, and I want to spend some time on this to show you. This is the one I saw quoted more than any other when I was doing the research on this. This is a study, I think, out of France, and they had like 12 centers. I have to say I'm very leery of the literature. I don't know what you think, but I did my fellowship at Louisville, which is one of the biggest hand centers in the country, and their research was with people who didn't speak English because we had fellows from all over China and everywhere. And the ability to write papers there was so bad I couldn't do it one day. I was trying to do one on PIP joint orthoplasties for people, and they didn't have range of motion. I couldn't write the paper. So I realized then that the literature is pretty weak sometimes, so you got to watch what you read, right? So this guy did this study, and he included all these people in it, and they had at least 2 months of conservative treatment and irrigation surgery, and they had pain or something like that, and they documented that as ORN for some reason. And they had the radiographic criteria. Does increased bone density, periosteal thickening, radiolucency mean you have ORN in people who had radiation? Is that true or not? No, it isn't? Okay. So he included these people, but he excluded people who had fractures or radiographic evidence of bone resorption to the inferior border. So this would be, a stage 3 or 4 in some of the people. Of course, cancer, or they had been treated before. And then he randomized these people into 2 groups. If it was less than 20 millimeters, they didn't have a fistula, and they had no need for surgery, put them in Group A. And then Group B, they had larger amounts of problem and they needed surgery. And I already told you why they wouldn't have it. So he took these people, I think it was 68 or something like that, 68, and he put half of them into a placebo group, so no treatment, and half of them got HBO, or so. And he randomized them into these 2 groups. None of them had surgery. They used multi-place chambers, the one I showed you. The thing is they didn't follow Marx's convection. They did them twice a day, so they get them done quicker. And I'll show you what the criticisms of this are. And they do 30 exposures. So they did that kind of stuff. Yeah, we've done people twice a day. Well, actually, we do them at 8 in the morning and 3 in the afternoon so I can get home by dinner. Yeah, some people need 3 times a day. There's only really one emergency center in the whole city, and it's John Davidson's at St. Luke's. So if people need emergency stuff, then they got to go there. They did the usual simple treatments. And they said the primary outcome was in patients who had recovered at 1 year. So they waited a year for some of these people. And they said they had no pain, they didn't have any bone exposure, they stabilized their radiographics, and they didn't have a treatment failure, which was defined at least one of the following. Bone resorption, or they didn't get cured by Group A. So they defined somebody as a failure where HBO didn't heal him. And we all know that from what I've had, 80, 90% won't heal anyway. So how can you call that a treatment failure? Because he's not following Marx's protocol. So he can't compare this to Marx's protocol. And this comes up later. Or a need for a surgical group, which shows you how much I remember when I put those up. Something's missing there. Where'd it go? I think it's probably me.
No.
Wow. But to make a, well,
You know what's amazing is the financial thing is that, what was it, 15 years ago, there was, St. John's was the only HBO center in this city 15, 20 years ago.
St. Luke's was first.
Yeah, John Davidson. Davidson was the first one.
Yeah.
I thought St. John's was the only one. Well, there's 2.
St. Luke's.
Now there's,
There's actually, I think, 8.
in town?
Yeah, so I didn't mention this. So we were the first accredited facility. We have UHMS, which is what we use, accredits facilities around the country so that they're all standard. You don't have big accidents, people blowing up. Some guy was doing it in a shipping container between two buildings in Florida. I'm serious. And so we were the first one in eastern Missouri. We were the 200th one in the country. Now Barnes, which has one, is accredited.
So everybody and their brother had it. It's like an MRI.
Well, I would think it's very lucrative. Now, granted, these hyperbaric units cost over $100,000. You have one big one, but if they get, I don't know how much, maybe they 15 patient. If you got 4 of them running 12 patients, you can make them a lot of money. And so these for-profit ones, which you mentioned, really make a lot of money. Actually, Chris Paletta, if you know Chris, was the medical director. I don't know if he still is at Healogics out on the East Coast. So they must be really lucrative. They don't pass it down, of course.
It's like the MRI set. My accountant, I went to do my taxes a couple years ago. My accountant goes, I'm investing in an MRI center. I said, you could be kidding. It is amazing that I grabbed this going.
You remember the first MRI center in St. Louis? It was on Hanley Road, and it was shared by every facility in the city. They couldn't agree where to put it, Barnes, Slough, St. Mary's, wherever, so they stuck it in Clayton on Hanley Road. And I remember we used to have to put people in ambulances to send them. Now, does Total Access have them in their places?
Everybody has CAT scanner.
Yeah. Well, that's another lucrative thing to yeah.
Everybody is a wound treatment center.
So I don't know where the data went, if it's still there or I lost it, but you know, there was a large number of the patients in Group A which didn't get surgery, ended up needing surgery, so they got moved to Group B. And actually the placebo group, for some reason, had a better healing rate than the hyperbaric ones. So then people went into Group B, and these included the group failures. And here's that.
What was the placebo?
I
think they were hyperbarics.
let's see.
No.
They
You sit on a beach chair.
Seriously, did they
Oh,
sit them in the chamber?
Yes. So what they would do is they'd put them in the chamber. They'd put them in the chamber and they'd give them 8% oxygen, which simulates 21% oxygen. But they'd also, the thing was, is they also gave them pressure though, up to 2.4, because they thought, well, they'd know it if they didn't get the pressure because the temperature didn't change. When you do a treatment, the temperature changes with physics, you know. So, yeah, they put them in the chambers, and Marx did the same thing. But the interesting thing, am I going the wrong way? No. Okay. The interesting thing was when they put them in Group B, and they gave them surgery, which was usually what, an alveoloplasty, 85% of the HBO ones healed. Not bad. But remember, they waited a year on some of these, and in the study, they didn't even bother to tell you how long they waited. But if you wait a year to do HBO after they didn't heal, I'm not sure that's a good way to do it because you need the surgery around the time you do your first 20 treatments. And after the second surgery, they all pretty much heal. So they decided that HBO didn't work, so they cut off the study. They said, oh, this line dips below this line, and that means it's significantly worse than even experiments. So they said, forget it, we're not doing it anymore. And this is a study that's quoted as HBO does not work. So the interesting thing about it, they went in, and this is in his paper, he said, well, more severe forms were not included for 3 reasons. First, the 12 centers that participated, which is a lot, couldn't even agree on the standard surgical procedure if they did one. 1/3 of them were reluctant to put their severe patients in the placebo group. So there's already bias in there, and so you can't really believe everything. So these are the criticisms. One, it didn't follow that it's an adjunct to surgery. The placebo group got the 2.4, but that's really not an issue. They excluded more severe forms, making the study biased. They had multiple studies, and everybody was different with their procedures. They shortened the treatment time, and no one knows a BID really works as well as daily, which we do 5 days a week. They think that not to take weekends off. They think that making the tissue hypoxic for a few days increases the chance of angiogenesis. I like it because I don't have to work weekends. And again, and basically they say, well, actually it answers the question of what Mark said. It's a multidisciplinary thing. We work together. We're not taking cases away. And what about this 1 year later thing? I don't know. But now there's a new theory called the fibroatrophic theory, which just means that there's not only loss of blood vessels, there's dysfunction of fibroblasts and radiation and all that and depletion of cells, and we don't need to go into it, but it's all these little areas here with the arteritis and inflammation. And again, guess what? There's another discussion going on in 2010 now where it says, oh yeah, you should use it, or no, you shouldn't use it. So we're still arguing about whether it's good or not. I just want to show you some studies that make no sense. This is one without HBO, some improved but very few healed. Then with surgery and without surgery, you can see how 73% healed with the alveolar and then 100% after subsequent surgery. So they were able to get them all healed. Stage 3, people with fractures and things never heal with hyperbarics, of course. And with stage 2, which is limited alveolar mandibular bone, they don't heal as well. So it sort of still says hyperbarics. I like this guy. This one was published in the Journal of Cancer Research. The guy put him on an antibiotic protocol, and I don't want to keep going forever, but it was a 10-year study, and amazing. Not a single case of ORN. Anybody believe that? Can you do it? It must be a god. He took out a lot of teeth, though, but didn't have one. So that's good. This is the one I mentioned before. This is a study out of oral maxillofacial surgery. Now, granted, low numbers. 4 patients operated on before ORN, and half of them got ORN. Before radiation. Half of them got ORN. That's pretty high. During radiation, none. But look at this after. 100 patients, sick. Now, granted, it's only 6, but everybody he took a tooth out of with radiation got ORN. That's pretty bad results. But this is the stuff that's published, you know. So this is, I know you asked me about the Pentox. This is something that may hold promise. Is anybody using this? Are you? So pentoxifylline is also called Trental. We used to use it to make the red cells more malleable. It didn't work in peripheral vascular disease, and then there's tocopherol, which is a vitamin E. But this is their effects. I won't go into it too much, but they anti-tumor effects, antioxidants. I don't know what dosage you're reading, but it looks like it was 400 for at least 8 weeks before surgery, they said. I don't know how long do you use it?
So prior to surgery, I'll do 2 months before, 2 months after. To have all right, I'll keep on doing it with HBO.
Okay. And then this one was 1,000 units a day. And I found that the length of treatment was from 4 months to 19 months. Okay. And then they had pretty good results. Individually, they don't work, but 66% after 12 months. There's a study supposedly going on in Paris where they did real well. There were only 16 references over it, so there's not much written about this yet, but it sure is getting some results. Oh, great. Okay. I don't know if you combined it with Comdurate, but it supposedly increases the same thing because it inhibits bone resorption and increases osteoblastic function. Where did all of it go? So this is a study I wanted to show you, but look at the ORN rate, 0.26% from dental extractions. High-risk patients, this is pretty darn good. But then they say in the study, well, our study's only observational and low scientific validity. There really isn't a good randomized study yet. So I don't know what to say long term. And they said, well, our data control is difficult, and they think they need to do more studies, which I think would be great. So basically, the ORN literature has its good and bad, pros and cons, yin and yang, whatever you want to call it. Many of the studies have low evidence. Some of them, very few are randomized and unbiased. The new treatments that you're using, how would it work if they did it with HBO? They should do a treatment with that, with HBO, and see if it helps. Maybe it works against it, too. Yeah. So where do we stand today? This is the real reason I'm here, if I bored you plenty. But the government has gotten involved. Every center is supposedly being audited, and we got audited within the last 6 months. The CMS is auditing us, that's Medicare. OIG is now asking us to look at every patient in the last 10 years and say, which ones did you not do it right? Do you not have documentation, and send us money back? They don't even want to review it, they just want you to do it. The reviewers, we have no idea what they know and don't know. As I said, they denied us with one patient on our audit, so we protested all the ones that we got denied on, and only one we couldn't. They basically they overturned the initial diagnosis of denying us in all but one, and that one didn't have ORN documented by the oral surgeon. So we don't even know what they're looking for sometimes. But remember, it's an adjunct to treatment, so we have to get you all involved and pester you and everything. But this is why I all got involved. In 2007, they found, when they reviewed them, 74% didn't even have the doctor at the center when it was being done. 15% were from ORN and 20% for arterial disease. They found that 22% were payments for not even covered indications, like a skin tear on a toe. So they really felt that something was going on. And in some ways they were right, because some things were not being done by the book. And then it took another 4 years for them to say, you know, we're going to establish a registry and we're going to start sending out denials for non-covered service. So that's 2005. Now we go to 2013. It took them that long to do anything, as you expect. And they found in 2013, because nobody was paying attention to this, and I can tell you, we didn't know about this back then, 58% of the charts were bad. I can show you something really interesting at the end. But these are reasons they did, and most of it came about because of diabetic foot ulcers, which is probably the #1 treatment in many centers. But they have to be really bad ulcers. You can't have any healing in 30 days. We had a lady we were going to treat. It took us a month just to get her approved because nobody had done measurements. And in the thing it says you can't have no measurable signs of healing. That means you can't just say it looks bad. You have to say it measures worse. And this lady got a millimeter better and we had to deny her. It's just crazy. And she could have done well with it. They found that the test, remember I told you about the test that was referenced in the physician diagnosis, wasn't even mentioned. So they want to know how you diagnosed it. It didn't even say whether you treated the whole body or the patient, the documentations, and whether there's any improvement. But this is all the same stuff. Is a conventional treatment, is an adjunct, and this is the diabetic things. We have to even say what their nutrition is, because if their nutrition's bad, we have to say they're actively treating it. We have to see what their hemoglobin A1C is, and if it's high, we have to say, oh, they're trying. Well, thank God they didn't say it had to be below 7 before we do it. I mean, this is all things. We have to remind them every day to wear something on their foot so they don't have pressure on their ulcer. Every day, and if it's not documented. There's other things. Just the orders, they said, well, you have to have an order in the chart every day. You have to document this. You have to tell us, when do you dive them? What do you do? How do you treat them? How long does it take to get what we call ascend and descend time? I mean, this all has to be documented.
How much more money is just to document all this stuff, like all these patient interactions, your chart out, like, it makes no sense to me. Like, have an order every day, like, you can bill every day.
Well, Epic helps a lot, but they do scan the order in every day at our facility, but Epic helps with documentation.
Has to go over the order, agree with the order, and therefore has an RV or a patient encounter per se.
Yeah. Yeah, it has to be done. Epic helps because some of it's auto, like my notes, it places all the data in there anyway because we've set it up so it auto transfers into my note, which helps a lot. Because if I had to go in there and every day put it in manually that they went in the chamber at 10:12, they got down to what we call depth at 10:18, they then took an air break in this 10-minute period, then they came up, I'd have to do all those by hand, what their blood pressures are and everything. I didn't put in one of my notes, but you'd be amazed. So basically, same thing, they just kept denying them, and I'll go through that. But here's what they found. And now, I have to tell you, I pilfered this in some of my slides from other people's lectures, but this is the error rate. West Virginia had, now granted, they only did 1799. 99 charts they reviewed in South Carolina, 90% were wrong. So you can see how they want their money. They say, if you don't do it the way we want, we're going to take our money back, 93%. It's all about money. It's not whether the patient deserved it or didn't deserve it, but look at these error rates. And so they told them that, and that was in 2016, and guess what happened in 2017? West Virginia got down to 85%, so they got 15% of them right. I mean, we ended up with 91% right. So we did okay with the audit, although they tried to burn us, and then they had to, during our review, we said, this isn't right, and so they redid them, and we were 91%. So at least we don't have to do it again. But you can see how the error rates are pretty bad. This is one day. This is a lady from Georgia. This is one patient day of charts they had to make for the government and send them to them by mail. And here's one chart that they sent. So you can see how, and they had to hire people just to do this. It's incredible. If your signature is illegible, they denied them. So I had to start signing my signature on these documents legibly. I don't know if your signatures are bad as mine, but I can't read my own signature. And then they said, well, now you got to attest to it. But they find ways to deny everything money, right?
Oh, yeah.
I didn't put it in there, but they're saving millions and millions of dollars supposedly. Then somebody up north said, oh, you need an ACLS card. You know, or, you know, it's just ridiculous. So we also fight the public. This is Michael Jackson, supposedly, 1986. I guess when in between his sessions with the anesthesiologist who was giving him propofol, right? But it came back again. This is on the Oprah show, I think in 2011. Dr. Oz is saying how wonderful this is. They wheeled this thing on the stage. They had this lady in there. The video's around, but the lady, Oprah goes, how is this? Oh, it makes me feel so soothing. I feel so good in here. Oprah says, take this to my office. I mean, really. The darn thing isn't even turned on. If you came by our place, we have oxygen, you know, copper tubings, all these tubings coming out of this. You can't just wheel this on stage and tell people it works. It's a joke, but they were acting like she was doing well with it. I guess if you watch Grey's Anatomy, like my daughter still binge watches it, they did one on necrotizing fasciitis, which is one of the covered ones in here. This is like a multi-place chamber, like you saw. I don't know why they're using oxygen masks because they don't need it. It's an air environment. But, you know, and look, they're gas masks. But I think the guy died, unfortunately. And it just came out. So this is all rippled on, and now it's hitting everybody, including you all. This is our protocol today. If we can do it for extractions, we do 20/10. If it's commercial insurance, maybe we can get away with it. But we have had to turn people away who come in and they say, do you have ORN? Well, we can't get it. And they found that when they sent out these audits to try to get the documentation, that 75% or more of the centers didn't even respond to them because they knew they couldn't do it. So for stage 1 ORN, so all these are, we do 30/10. We don't do 60 treatments, we do 30/10. And like today, if it's less than 4 years, we usually just say, let's do 10 post-surgery. So you have the surgery come in the next day, hopefully. And after 4 years, we usually say, you better start over. Sometimes you fudge. This is where you guys get involved. We have to have documented ORN. There's no way around it anymore. We have to ask for the diagnostic tests, what surgery you're going to do, and a referral, I guess. And then we have to do all the other things. We have to find out how much radiation. Because if they had 4,000, do we do it? We still do it. Because they haven't told us that less than 6,000 is the only way they'll pay for it. So we still do it because I still think they get radiation damage, you know. But they haven't proved it. Like on the maxilla, they're trying to say that you don't need it at all anymore. I don't know if that's going to come into fruition, but we still do it for maxillary teeth. We make sure I sign my name right, or we have to check, like I said, blood sugars, nutrition, offloading, things like that. Find out what chemotherapy they're on. This is the form that we have. This is the introductory letter. You don't want to see that. But this is what we'd ask you. So we'd send this form to you. We may write the name on. I don't know if they do. But you have to say yes or no. I try to make it as easy as I can and what it is. If you just go yes or no and you think they have ORN, physical exam, fine, we're done. What the procedure is and sign your name. They haven't gotten to the point and say, well, we need to see the X-ray or the Panorex to make sure. They go that far, they're really going crazy. I mean, we trust you all to make the diagnosis and do it. Because we all know it helps. We just have to prove all this stuff. This is the form that our office manager makes out on what we go through with ORN, trying to make sure we check every box, we dot our I's and T's. Because Sister Rock will join us someday and try to take us out. No, she doesn't work there anymore, does she? You know, she did tell somebody why she gave up control of St. Mercy's. Did you hear that one? Because there's no more nuns. So Ashworth took over, right? And then he's gone. But this is the thing they have to make out, and I'm sure they'd close us down. They actually almost closed it down twice, I heard. But we have to say what's going on, and we have to send that to you. This is one we saw today for soft tissue radionecrosis. He's got hemorrhagic cystitis, so we filled this out. I don't know if you know Keith Steinbecker and whatnot. So we're going to try to do, he's actually had it in 2015, and now he's got recurrent hematuria from a different site. They really do well with hematuria. I've seen him go from bloody urine to microscopic to no hematuria. We actually did a lady who had cyclophosphamide. I don't know if you guys ever use it. And that's one of the risks is hemorrhagic cystitis. And she went from being in the hospital like three times a month for blood transfusions to never having another one. Yeah. Yep, that's it. Thank you. So unfortunately, making it hard on us has made it really hard on you all. I don't know what the other centers do. I know you said Ludwig's making you fill out forms now?
I deal with you.
Okay.
I'm gonna leave
So
it
I'm
at
making
that.
you miserable.
I'm gonna leave it at this. I deal strictly with you.
Yeah. You know, I trust you all. If you send it, they need it. But you know, the powers that be think we have to fill out the forms and everything. And the OIG is the next big obstacle because the Office of Inspector will come and say, we're going to go through every chart and we're going to take back all our money. And then we won't.
It's getting worse and worse, man.
Oh, yeah.
You know, all the accreditation, all that.
Mm-hmm. What do you want, Bernie? You heard what Bernie just proposed a couple days ago?
No.
Health care for all through Medicare. Somebody said, well, can people get private insurance? No, they won't need it anymore. But he wants to do it for even dental work. Is there any country that covers dental work in?
No.
I didn't think so.
Germany.
Germany?
Yeah.
But they want to cover dental work.
Canada is one of the hardest countries in the country to get, or in the world to get a dental license. The reason being, they're not government controlled.
Oh, thanks.
So
Will you make it to go?
the highest paid professional
The stir fry. Thank you. Thank you.
being a dentist.
Thank you. Yeah.
Excellent lesson.
Hmm? Oh, thanks.
No, that's awesome. So, if they're denied, do you document, like, why the OIG denied them? So I guess for us, I guess, question, you know, we send a patient your way, they get, you know, the preemptive dives, right?
Well, we won't put them in until everything's done.
Yes, so I guess the question for us, like, so if they're denied, you like, so I think it's more for us a CYA, right? So and now we're like, well, now we're taking out your teeth, you want to pay for it cash, because obviously it's very, you know, expensive.
Right.
So I guess you guys document any way saying, well, this was denied by the OIG for these reasons,
Or you don't even submit it, so if we say there's no ORN, there's no point in you even going through it.
Now, unless they want to pay on their own, yeah. Now, let's just say you say ORN and they decide you didn't, and they deny us because I forgot to do so. We write it off, as far as I know. They don't go back after the patient. They won't. It's not fair to the patient to say you're covered and then go back afterwards. Yeah.
There's no evidence we're really doing it prophylactically, and we're going by the book and saying, no, I can't document that. Then we just document that the patient wouldn't pay for it on their own. They develop
Well,
ORN.
that's what I'm kind of getting to, like, you know, like how do we cover our asses from lawyers?
The only way you do it is this is the treatment
Yeah.
that's recommended. Patient refuses treatment for whatever reason, it doesn't matter, right? Patient refuses treatment.
How many of those ORNs are gonna get free flap anyway? Prophylactic treatment is probably the best thing you can do.
Absolutely.
It's not gonna be covered.
I mean, that's the logical argument, but it's
Right.
relying on logic, right?
Covered doesn't have to deal with lunch.
Yeah.
But you are getting, because we would get reasonable success with prophylactic dives with private carriers. In the St. Louis market, is it the same?
Some of them.
I know Davidson, I mean,
Oh.
we still don't get the questionnaires from those guys when we send the cases.
I
don't know, I guess that's coming.
I don't know. I'd ask Davidson. St. Luke's may have said, I don't care. We'll do it and we'll write it off if they don't. Now they do, I think they do a lot more of the diabetics than we do, so it may be a smaller part of their practice. But the question would be to Davidson is, what's going on with this? If you see him and talk to him, it'd be great to know.
I'll have to ask him.
Yeah,
Because, I mean, we sent a fair amount over there.
yeah.
I got one covered prophylactically in the fall
Somehow we
From-
covered-
from Medicare for HBO.
By, theoretically, that should not have been covered. Yeah, but
Yeah, and you're
more
right,
power
they
to
may
you.
have- They may have written it off or just not told me.
More
That
power
was
to
a
you.
sad deal.
Because I mean, if I was sitting there and I knew my chances were 30%, I'd call that bad. That's not good. I like less than 1%.
At least send it to you before they do radiation.
Pacemaker.
Before radiation.
Yeah.
Right, usually do. The day before, right, huh? Yeah, that would, right.
care, but I guess my brother's Christian, I said to you, I guess he can't be treated at Mercy, I guess big Mercy because of his pacemaker.
Might have been requested one, but when you do those people and you turn it off, you like to be able to monitor their heart rate. Did he go to St. Luke's? Oh yeah, South has one. Good. We've asked for one, and we just haven't been able to get one. The boss, the administrator, is looking for one, but it has to be a regular old one, regular monitor. Can't be one of these little handheld ones. So it's like, I forget how much it costs.
It can't be a portable monitor that we use in our office every day.
It can be a portable, but we like to have more than one lead. And we do have, these units have what we call pass-through, so we can put electrical EKG. But I don't have one, and I would do it because, okay, I had a guy, I may have been your guy, he hasn't had it go off in 4 years he's had it. It ain't gonna go off again. I said, just let him go in there with it. What's the chance that even if he gets defibrillated inside, he's gonna get static electricity that's gonna cause it to blow up, if it's buried? Almost zero.
Yeah, like, if you have a monitor inside the chamber and it's full oxygen, yeah, you're monitoring when it goes off and it's shocking the old man.
Well, we turn it off. We put a magnet on him.
Oh, prior, okay.
Yeah, you put a magnet on him, and then then it doesn't go off. If he goes into VFib, you just takes you 2 minutes to get him out. We emergency vent him and take a chance that they'll get a pneumothorax or something. Get him out. Knock on wood, it doesn't happen. Those things don't happen much, but the powers to be, my bosses said, no, we're not doing it. We don't want to take a chance unless we have a monitor. I said, do it. I don't, the chances this guy's going to have a problem. Oh, how many of them do you think they have sitting around in they have a facility in Earth City where they take all the older units. We don't care if it's an oscilloscope from 1950 if it works. So yeah, it's a problem. Yeah, it's too bad. But we try to get them in and hope for the best. But luckily, the hospital doesn't usually tell me no. My manager's very cautious, so they didn't want to put them in. But unless it's really bad, I mean, I put a lady in with an ejection fraction of 30%. Now her cardiologist